To all the audience, in about 1 minute, we're going to start Dr. Paul Park lecture. Thanks to all the audience who follows our broadcast. We have the honor today of having Dr. Paul Park. Dr. Park is a professor of neurological surgery and orthopedic surgery, director of neurosurgery spine program at Michigan Medicine at the University of Michigan. Today, Dr. Park is going to share his lecture, The Impact on Enabling Technologies on Minimally Invasive Spinal Surgery. Please type write your questions in the Q&A panel. I will read them at the end of Dr. Paul Park lecture. Welcome, Dr. Park, and thank you for sharing your time with us. Your microphone is all yours.
Thank you, and I appreciate the introduction. And I also want to thank the IWBNC program organizers for giving me the opportunity to present my talk on the impact of enabling technologies on minimally invasive spine surgery, which is an area that I'm a big proponent of. Here are my disclosures. So I want to begin by talking about what are enabling technologies. I just want to define the term because it's something that actually is talked about quite a bit. But it's important to define what the term is. And Wikipedia defines an enabling technology as an invention or innovation that can be applied to drive radical change in the capabilities of a user or culture. And I'm going to highlight drive radical change in the capabilities of a user. And that's what I'm going to really focus on. I have a couple examples of enabling technologies as pictures. One is the phone, and the other is an electric motor, which I think has a lot of press these days with electric cars. And these are no question enabling technologies that really drove radical changes in our society. Another characteristic of an enabling technology is that it will evolve over time. And what I mean by evolve is as a technology is refined, it undergoes multiple iterations, it improves. And examples for the phone is the cordless phone, for example, or non-rotatory, I guess would be the first iteration, then cordless, and then mobile technologies are obviously. And so as you see over the years, as the technology is refined, more features are presented, and it just overall, it's a much better working technology and more reliable. Same thing with electric motors, and now electric motors are used in cars increasingly. So when it comes to spine enabling technologies, I think there's no question that the pedicle screw and the screw rod construct are huge inventions or technologies that drove radical changes in our capabilities to treat our spine patients. Prior to pedicle screw fixation, for example, we were relegated to using hooks and sublaminar wires, and fixation just was not great. We could not treat a number of very significant conditions adequately. But the pedicle screw and the screw rod construct changed all that. So I think there's no question this is an enabling technology that really drove radical change. The polyaxial head is just a refinement on the pedicle screw, the fixed pedicle screw head. And obviously percutaneous pedicle screw rod construct, when talking about minimally invasive spine surgery, was a huge advance as well. So these are all enabling technologies that have really changed our capabilities. Another enabling technology, and this is the one I want to focus on because it has such a big impact on minimally invasive surgery, at least in my mind, and that's my opinion, is spinal navigation. And the reason why is there's two big barriers to adopting minimally invasive spine surgery. And this is just not my own opinion or thoughts. It was actually, as I recall, a question posed to a group of surgeons at one of our society meetings is why don't you do minimally invasive or perform minimally invasive spine surgery? And one of the biggest roadblocks or hurdles was the lack of direct visualization of the anatomy. When you do a traditional open spine operation, and we do a lot of posterior surgery, obviously, we strip the muscles off the bone, which is actually the morbidity associated with open surgery, but it exposes the bony anatomy. We see the spinous processes, we see the joints, we see the transverse processes, and that automatically orients you. And we do it subconsciously, but we know where midline is. We know our trajectories, like we know roughly what 30 degrees is, for example, if you're putting a pedicle screw in. And it's done almost subconsciously because we could see the surrounding anatomy. But with a minimally invasive procedure where your field of view is very narrowed, if you're using tubular retractor, for example, and you only have like an 18 millimeter tubular retractor, and you don't see much of the anatomy. So there's this concern of being not in the right location or having an incorrect trajectory leading to a complication. I think it's a very valid, actually, concern. I give another talk on complications for minimally invasive spine surgery, and that's the root cause of a lot of complications. So it's a very valid argument. The other issue or barrier is the fact that because we don't see the anatomy so well, we're reliant on something other than our eyes, and that's typically fluoroscopy. And we're, as a spine surgeon, we're all comfortable with fluoroscopy. However, there's downsides to fluoroscopy. It's 2D guidance, so even using a fluoroscope, we can be misled in terms of our trajectory or localization. And it's also associated with increased radiation exposure. And I, as a minimally invasive surgeon, when I first started, there's no question I had an excessive amount of radiation exposure. I would hit the 5-minute warning on a fluoroscope, not infrequently for multi-level minimally invasive cases. And so as I've gotten older and understand the dangers of radiation, it's become a big deal to me. It's an occupational hazard. And if we could avoid radiation, I think it's much better for us as surgeons, just in terms of our livelihood. So the impact of spinal navigation is huge in this sense of overcoming these two barriers, because with 3D navigation, with our ability for localization, seeing the surrounding anatomy, and with trajectory views, this kind of minimizes all the barriers that I've just mentioned. And I'm going to sort of show that in my presentation. And it's going to be a step-by-step approach where navigation has evolved to become this, I think, very useful tool. And again, it's an evolution in technology, again, which is sort of a characteristic of an enabling technology. So I just want to give a little bit of a historical perspective on spinal navigation. I'm not going to dwell on this. This is not really a didactic talk so much, but I think it's interesting to see where technologies come from. And I'm interested in history to a certain extent as well. So spinal navigation was introduced in the 1990s. So now it's 25 years or so, maybe longer than that. And it met the need at the time for improved accuracy of screw placement. In the 90s, pedicle screws was still new technology. So placement of pedicle screws was difficult. We didn't have our comfort level. We didn't have maybe some of the techniques we have now for placing pedicle screws without, say, navigation. And so this is one of the first papers, and it was just a laboratory paper looking at image-guided insertion of pedicle screws. And it's a proof of concept in the laboratory. And you can see here's the technology and the diagram showing the feasibility of using this for screw placement. And, I thought it was interesting to see that 1995 is where all the laboratory work was being performed. And that translated into clinical application, obviously. Worked in a lab, and it was transitioned to, clinical usage. And early spinal navigation, like all new technology, had issues. And I think we're very familiar with that. Whenever we see some new technology that looks great, it's advertised. It's not necessarily spine surgery, but any new technology, we may purchase and use it, and we find it doesn't work very well because it's new. It needs to work. There are a lot of usually bugs with new technology that needs to be worked out. And it was no different with spinal navigation. The initial iteration required preoperative CT, so you had to get a special type of CT, and intraoperatively required surface merging to the spine. And maybe people aren't familiar with that, but we had to register the CT that's on a computer station to the actual spine, and that required manual point registration. That was a time-consuming effort, and it was unreliable at times. And the other problem with early spinal navigation wasn't widely available. It was not in all hospitals, for example, and it was costly. Here's just an example of the point surface merge that was required to register the preoperative CT imaging, which is on a computer, is a 3D model, to the actual spine. And this is using a pointer that's registered and picking points on the actual spine. And this kind of onlays onto the computer model to register it. And so navigation is feasible. So this is a paper, so it entered clinical practice in late 1990s. So this is a paper from published in 2000, so 21 years ago. And they looked at, in a randomized study design, 100 patients, 50 in each group. And they noted that screw accuracy was much higher with navigation, so it's not a surprise. And since this paper, there's been numerous articles, high quality evidence showing the accuracy of navigation for particular screw placement. And one thing they noted, though, was that the screw insertion time was higher with navigation. And that's not a surprise. Early on, navigation required much more time for insertion. One, it's the surgeon getting familiar with the technology. The other is the technology was time consuming. And again, it's early technology, and as it's refined, that this sort of problem goes away. But at the time, it took much longer to use navigation. And reliability was the other issue. Again, with new technology, reliability can be a problem. And of the 50 patients in the navigation group, there were 9 dropouts. So almost 10%, or actually almost 20% of the time, navigation didn't really work very well. And the reliability issues were inaccurate pre-op CT, malfunction navigated pedicle probe, et cetera, as computer hardware failure. So again, this is just a reflection of new technology. Another issue obviously was cost and expense. I think, as technology improves, cost comes down, and as it improves, the value argument can be made that it actually provides an important component, and with the cost decline in the cost benefit ratio, or cost ratio is improved in terms of a hospital acquiring the technology. So at least in the United States, all hospitals have navigation now. So contemporary spinal navigation, again, most if not all hospitals, at least in the United States, have the technology, because for brain tumor surgery, for example, standard of care, so all hospitals have it. And accuracy has been absolutely confirmed. And time efficiency, which was the other issue with this new technology, has really improved markedly, to the point that I would argue that, at least for multi-level spinal procedures, utilizing navigation is much quicker, actually, for screw insertion. And there's some data to support that. Intraoperative image acquisition is a technology widely available now, so you don't have to use a pre-op CT if you don't want to, but you can always have the ability to use a pre-operative CT. So there's just much more adaptable to the situation with current technology. And again, I don't want this to be a didactic talk, but I just want to show a little bit of evidence showing that technology will evolve over time, and with that, time efficiency. And this is a paper that was published actually a number of years ago, looking at percutaneous pedicle screw placement with traditional fluoroscopic guidance and 3D CT navigated guidance. If you look at this study, they used sort of an order technique for navigation, which is, I think, no longer done now, because this was a K-wire based. So Jamshidi and K-wire based use of 3D navigation, which again is no longer necessary. So it's even faster now. But this is an older paper, and this is just showing the intraoperative image acquisition and the screw insertion utilizing navigation. And I want to highlight a few points here. One, navigation, again, is more accurate. Again, I don't think there's any question of that. And then the operative time was much quicker now, significantly quicker, utilizing navigation versus fluoroscopic guidance. And this is for a one-level operation. I would argue with more than one level, this time efficiency improves dramatically. And again, this is with sort of an older technique that was more time consuming using navigation. And so I want to kind of highlight some of these concepts with some videos, which I think go a long way. The videos aren't very long. So I'm going to start off with like traditional fluoroscopic guidance, show what the evolution of of navigation and how it could impact the surgery. Again, it wasn't seamless and it was a step-by-step process. So I think videos are very important. So this is an example of a traditional minimally invasive T-lift and how it was done. And you can see the heavy reliance on fluoroscopy. So this is a patient that we see all the time, grade 1, spondee with high-grade stenosis at L4-5. Now, obviously a surgical candidate, particularly if they fail conservative measures. So positioning is very straightforward. It's prone on Jackson frame, but I typically use 2 fluoroscopes because you need AP and lateral views to do the procedure. You can use 1 fluoroscope, but that becomes even more time consuming from going AP and lateral on multiple occasions. So 2 fluoroscopes is usually quicker, but even with that, it is time consuming. And what I want to highlight is the fact that I have to use fluoroscopy at every step, localization, to placing the sheeting needle to traverse the pedicle, because I just can't see the anatomy, right? We don't see the spine that's exposed fully. We're using small incisions. And obviously this is doable under fluoroscopic guidance. I've done it for a number of years and I believe I became pretty facile with it, but there was no way of avoiding fluoroscopic usage and a fair amount of fluoroscopy, which adds up over time. And like I said, so radiation exposure, and I think particularly with more than 1 level operation, which I'm going to show you, it's very time consuming. So again, very doable here. And once you do it a number of times, I don't think it's dangerous, and it's very straightforward. But look, after the K-wire placement, I have to dilate to put a tubular tractor to do the T-lift. And again, fluoroscopic usage there too. I don't show all the pictures that were taken, but a number of fluoroscopic pictures need to be taken to be done safely because you don't see the anatomy. And once the tubular tractor is docked, this is a relatively straightforward process. This is drilling the laminotomy and then a transverse cut through the pars interarticularis, inferior facet being removed. I see the video sped up just so it's not time consuming. I'll decompress the contralateral side. So I wand the tubular tractor to the other side and undercut the lamina. Very doable. Ligament of the flame was resected, and so you could decompress the contralateral side, so a direct decompression. Although nowadays I think people are into indirect decompression with distraction, but again, direct decompression is very feasible, minimally invasive approach. Now this is just the cage placement. Again, and I don't show this, I'm typically using fluoroscopy, particularly early on when you're developing your experience level, to make sure you're in the right location. Because I don't see that much through this tube. You see very little of the surrounding anatomy, so you don't want to be lost in terms of your orientation or trajectory. And that implies using fluoroscopy fairly repeatedly. And this is just the cage being inserted after biologic, and you can see it's doable. And I'm checking with fluoroscopy here too, that the cage is adequately positioned. But you can see that how many steps that are involved using fluoroscopy. And again, it's very doable. I did a large number of cases within this format, and there are no issues. But I was frustrated, and I'll show you why, with multi-level cases about the time that's involved in the degree of fluoroscopic usage. And again, I think for new surgeons, who aren't comfortable not seeing the spine, not seeing the anatomy is a real big barrier. And you can see I don't see the anatomy hardly at all here during this approach. And I'm just going to progress this because you don't have to spend too much time on it, but you can see it's very doable. See, with the MIS approach, got a good decompression and reduction of the spondylolisthesis, and you'll see that the direct decompression works really well. It's a very feasible procedure with traditional fluoroscopic usage, but it is a barrier for surgeons who want to adopt this technology if they're not comfortable with that. And this is I want to show in this video the next step where, you don't have to use fluoroscopy for screw placement. So this is a transition point for me. This is another MIS T-lift. And so in this workflow, I've already put the cage in, and I did use fluoroscopy for that. But once the cage is inserted, I'm going to actually use this enabling technology, which is spinal navigation, to put the screws in after the fact. As you can see here, I'm not going to have a fluoroscope in the field of view at all. So this image acquisition device is positioned in the field. We get a 3D image, which is auto-registered to a navigation system. And it's a simple 2-step process, no gem sheeting, no K-wire. There's a navigated alt tap at a sharp point to start your entry site. Then we're going to create a particular track. So it'll be a simple 2-step guide wireless process where I'm going to create a particular track here. Under navigation, this is done a number of years ago, so that you don't see that screw representation here. But once a particular track is created, I'm just going to insert a pedicle screw. So a simple 2-step process. It takes less than a minute per screw, if everything goes as expected. You can see the screw is inserted here. Again, we don't have a screw projection. This is but this is one of the first iterations of this. But you'll see that in subsequent videos that there will be a screw projection. But again, two-step process. Placing the screws. The TLIF cage was already presented, already inserted, utilizing traditional fluoroscopy. But I'll show you in a later step with navigation. Every aspect of the procedure can be performed in navigation, which I think again lowers the barrier to adopting a minimally invasive procedure. If you're not comfortable without being able to see the anatomy directly. And so I'm going to just progress through this because I have another video to show the issues with a multi-level case using traditional fluoroscopy, and particularly with a deformity. So this is a patient with significant spinal deformity. And I've already done the laterals here using fluoroscopy, which I don't think needs to be done anymore. But I just want to highlight how much fluoroscopy usage is required for a multi-level case. This is like an 8-level operation, but you can see AP and lateral fluoroscopy, how many pictures that need to be obtained. I think I used over 5 minutes of fluoro time here. And with a deformity, which this patient has, it's constantly wig-wagging the fluoroscope to get an orthogonal view, and then tilting the patient so that you have an orthogonal view on AP to place these K-wires safely through the pedicle. It is a huge amount of fluoroscopic usage here. And I'm just showing you the screw placement. I don't show you the fluoroscopy that was used for the cage placement that was done laterally. And again, this was done over like a decade or more ago. But it's just a significant amount of fluoroscopic usage. Here's placing in the thoracic spine, obviously. And, again, 5 to 10 minute fluoro time and time consuming. The technician has to go through AP and lateral multiple times at each level. So a huge amount of radiation exposure, but doable. And here are the x-rays to show that. So fast forward, and for these multi-level cases, it can be done in a simple two-step process that I showed you in the one-level case. I'm just using navigation here. I'm not wearing lead. There's no fluoroscope in the field of view at all. So this is just all done by technology. And enabling technology, and I'm inserting screws for a multi-level operation. And so I don't get any personal radiation exposure, and it's actually much more time efficient. I could actually plan where the screws are a little bit easier than fluoroscopic based. So this is a huge step forward, I think. But the caveat here, and this was years ago when I was doing this, is I'm not using it for any other aspect of the procedure. So while it lowers the barrier for putting percutaneous screws in, I think for patients who aren't familiar, or surgeons who aren't familiar with using fluoroscope to do that, it doesn't really help you with other aspects of a minimally invasive procedure. But this was years ago, and technology has evolved. As I said, that's an aspect of enabling technology that will evolve over time. And so if you look at where spinal navigation has gone, it can be used for almost every aspect of the procedure. For the retractor placement, say the tube for TLIF or lateral, for example, the decompression, you could assess the extent of decompression. Now we have navigated drills. So you could actually navigate drilling. So it could help you with the decompression because you can be very precise in what you're decompressing. Cage placement, whether it's TLIF, laterals, any sort of cage, navigation is very helpful with that, and it minimizes the need for fluoroscopy. Other aspects of procedures, like I've been talking about degenerative disease, but like tumor resection, corpectomies, osteotomies, navigation can impact every aspect of this procedure. I could actually list more. Here's just an example of using a navigaceotome to do an en bloc resection. Navigaceotome to do PSO, you can be very precise in your osteotomies. But I really wanted to focus on how navigation impacts minimally invasive procedures. So the lateral lumbar antibody fusion is a huge, now I think, or popular minimally invasive technique. And I'm going to highlight how navigation really can be used in every aspect of the procedure, and it does lower the barrier for entry. And I've seen that in my own institution. I think we all use navigation, all spine surgeons do when they use when they perform laterals now, because in a way, it's helpful because for the average neurosurgeon, they're not as comfortable with the anterior or abdominal anatomy. It's unfamiliar. We're very comfortable with posterior approaches, but not so much with anterior approaches. And so having the ability to see three-dimensionally the structures like the great vessels or potentially where the kidney is actually very helpful in overcoming that initial barrier to trying this approach. And I think it would be safer. And it does minimize the need for fluoroscopy. I'm going to show you how navigation can be used for every aspect of the procedure. So In a typical straightforward case, at least now for me, I don't use a fluoroscope at all until the cage has already been positioned. Once the cage is inserted, I get a spot fluoroscopy to make sure it's adequately positioned, because I've become very comfortable with the technology, and I'll show that to you. So this is positioning for the patient. Just use a Jackson flat and just a roll to open up that interspace between the lower rib cage and the iliac crest. And you need to securely tape the patient if you're going to use this technology, because you don't want any motion, because that could result in a navigation error. So you have to follow some key steps here, but secure the patient laterally, place a reference frame. That this could be either in the anterior superior iliac spine or the posterior superior iliac spine. It depends on what level of spine I'm treating that I place these pins. Typically, if I'm doing L4-5, this will be more along the posterior superior iliac spine. Image acquisition. Now you can use a pre-op CT and register with using fluoroscope intraoperatively, but I do have access to this technology, so I do use intraoperative image acquisition. And I get one spin, and that incorporates 4 spinal levels, like from L1 to L5, for example. And I don't have to respin at each level. That's a frequent question I get asked. Do I have to get an intraoperative CT at every spine level? That's not the case. Actually, you can do all 4 levels. There may be a little bit of motion error after cage placement, but it's really not that big of a deal. And I would argue you don't need sub-millimeter accuracy for placing these cages in the disc space. A couple of millimeters of error is not that big of a deal, because we're putting a cage in a relatively large disc space. What I would recommend is, so the frame is in the iliac crest, is starting farthest away, like L1, 2, and then marching toward the frame to minimize any sort of navigation error if you're going to use this technology. This is a very important tool. It's a multifunction tool. It's a navigation pointer, nerve stimulator, initial dilator. So it's multifunction. You're going to see this quite a bit in my videos that I'm going to show you here, that how useful this is. So it accomplishes 3 different roles. And this is just an example. So I'm going to use that navigation pointer at the skin. This is how I mark the skin incision. I project a point. So on navigation, you can project a point like 200 centimeters beyond the tip. And this gives you an idea of where that, where the trajectory of that tip is pointing. And at the skin level, I'm going to mark a point that's orthogonal to the target disc, like I'm showing here. And that's how I make my skin incision. And I'm not using a fluoroscope at all, so I'm not running lead during this procedure at all. And then once the skin incision is performed, I split the abdominal musculature into the retrogradial space, and I'm using this navigated dilator. Now, you don't see a yellow point at all, because that's a projection line. So that tip is where the blue point is. And I'm going to traverse the psoas muscle. And you can see the psoas muscle here. I don't know if you see my mouse. Here's the psoas muscle. I'm traversing it, and I'm entering the disc space. So I'm going to anchor by pushing through the annulus, this navigated pointer. It's not very sharp, but it's pointy. And I'll push it into the mid portion of the disc space, and it'll stay there because it's embedded into the disc. And then the tracking frame is removed, and I sequentially dilate. This isn't done under navigation, but the initial dilator is anchored into the disc space. And then I'll put a tubular tractor there, and it should be centered over the center point of the disc space. And this is the view you know, obviously I've done a discectomy here, but you see the psoas muscle, the residual psoas muscle, and then the annulus and a discectomy being performed. And this was done under navigation without fluoroscopic guidance. You know, again, I don't want to say you should totally ignore fluoroscopy. If something doesn't seem right, or early on your experience, you should use a fluoroscope to make sure it conforms to what you're seeing with navigation. So again, navigation is not perfect. So if there's any question, just get a fluoroscopic imaging. But once you get comfortable in your experience with the procedure, you'll be able to tell if it's accurate or not. There's a host of navigated instruments like this navigated cob, raspers, you know, cage insertion. And just an example of a navigated cob doing contralateral release here. Again, not using a fluoroscope, but again, if you're concerned at all, use a fluoroscope, get a spot fluoroscopic image to confirm that navigation is accurate. Rotate shaver, navigated trial, cage placement, all done under navigation, obviously. And here's sort of the pre-op and then the intra-op, you know, after cage is placed. And you can see navigation can be very highly accurate. And I showed that in multiple iterations here. Well, what about a oblique or anterior psoas approach? Navigation is very useful here. I find with oblique approaches, when you're using fluoroscopy, you tend to use quite a bit. And here you don't necessarily have to. And I often use this at L4-5 because of the iliac crest. And it's easy to do with navigation. I just mark an anterolateral flank incision based on where the pointer projection line shows. And this is not showing that, but this is a pointer anchored in a disc space where I'm going to sequentially dilate. Then I'll do the procedure just like any other procedure. Yeah, with the navigated trial, then the cage insertion. This is just an intraoperative picture. You can see this is not a traditional transsosal approach, but an oblique approach here. This is placed on the sort of the anterior lateral flank. This is a cage placement done under navigation. As you can see, it's fairly orthogonal because once the cage is partway inserted, I'll just turn the shaft of the cage inserter toward the posterior aspect of the patient. That makes the cage more orthogonal. And I have an intraoperative video, which I think is very helpful in driving home the points I've just made here. So this is an older patient who's had a laminectomy at L3-4, okay? And so she has a little residual lateral recess and foraminal stenosis, but that's not the big issue. You see that on X-ray. So if you can see here at L3-4, this is well lined here, no spondylolisthesis at all. But what can happen with a post-laminectomy situation is you develop instability and you get spondylolisthesis as seen here, right? So this is a painful level for her now. And so I'm gonna treat this with a lateral and fork screws. And this is done all under navigation. The patient's position, like I showed you in that other example here. And the incision is made based on the navigation. So we're not using a fluoroscope at all here. And the navigation frame is in the anterior superior iliac spine here. So this is basically a 1-inch incision. We'll highly magnify that to show it to you, but it's basically 1 inch. You'll see that because our fingers are gonna look huge here. So I'm gonna split the abdominal musculature based on this incision that was marked by navigation, and we're going to insert the retroperitoneal space. This is just the abdominal musculature. There's a fat in the retroperitoneal space, and we put our finger in. You can see the incision is not very big. It's a thin retractor. There's a psoas, and that's a navigated pointer that's being inserted or traversing the psoas to anchor into the disc space. So you anchor there. So we're not using a fluoroscope here. There's no, you don't see a fluoroscope in the field of view at all. And then we'll stimulate to make sure there's no nerve surrounding our insertion point. And then we'll just dilate with the nerve stimulation and put the tubular tractor in place. Again, this is not fluoroscopic based. This is all navigation based. And I truly think this lowers the barrier to using this technology because you can see the surrounding anatomy. And there's the residual psoas muscle. I'm just using a Kittner here. Not much psoas. We've traversed like 90+% of the psoas here with the initial tubular retractor. There's a little wisp of psoas here at the bottom of the retractor, and there's the annulus of the disc space. We're just going to now do a standard discectomy. I think positioning retractor and getting it in the right position is like half the battle sometimes. Once you're able to do that, the actual discectomy is not that difficult. Navigated COP, doing the contralateral release here. Just a discectomy, and we have a host of navigated instruments. And it navigated cage inserter. That was a navigated trial. I'm sorry. Yeah, biologics, and then the cage is going to be inserted. You can see here, navigation is used at every aspect of the procedure, from the skin marking to the cage insertion. And so the first fluoroscopic image that I often obtain is after the cage insertion, and there you see it. So good reduction, good height restoration, compared to like the collapsed disc space that we began with, right? And so, again, the video, I think, highlights the main points I was trying to drive home. And I think where you see the biggest benefit for navigation is multi-level cases, particularly with deformity. I want to show a short video about that as well. And you'll see a definite savings in amount of radiation exposure you receive for multi-level cases using navigation. And particularly with deformity, I think it's safer with trajectory views, particularly when there's a rotational component. Having navigation can help you not put a cage into the canal or outside the canal or outside the vertebral body disc space. And I definitely think there's a potential time savings here. And I think this video kind of highlights a point because one, it'll show not just a traditional transosal lateral, but a retrodiaphragmatic approach, again, which is unfamiliar anatomy to a lot of surgeons, at least at the beginning. But having navigation, being able to tell ascertain where you are during the approach can be very helpful in allowing you to do the procedure. And I think it lowers the barrier to doing it. And so this is a patient with a clear-cut kyphoscoliosis. You can see the coronal malalignment. It's about 10 centimeters off to the right, and definitely positive sagittal balance as well. And he's got a relatively stiff spine here, and I'll show that, and I'll show how navigation will be very helpful here. And this is this first stage we'll be doing multi-level laterals, and I'm going to do laterals from, this is T12, L1, 2, 3, and 4. So I'm going to do laterals on a concave side of this curve, okay? And that'll try to release this anterior column so that the posterior aspect of the operation can be done much more smoothly. So I'm going to use navigation. Actually, I'm not going to show it in this video to break this fusion at L1-2. I'm just going to show the T12-L1 approach, which I think highlights how navigation can help during the approach at this level, because the diaphragm needs to be taken or retracted. Here's positioning like I've shown you for the other ones for the lumbar. Here's the skin marking. Again, I'm just showing how I mark the skin. And for this particular case, since I'm on the concave side of the curve, I'm going to need 2 small incisions to address the 4 levels. So for T12, L1, and L1-2, I'll use 1 incision. And then because of the concavity, I'll do a separate incision for L1-2 and L2-3. And the incisions aren't very large. I'll show you to you. They're about 2.5 inches. So I'm just measuring it, showing you the length. And, for at 12-1, this is a T11 rib. It's a barrier. So I normally remove it, and I'm just going to remove about a 2.5 centimeter segment of the rib, not very large. Here's just a doyen, just stripping the tissues off the underside of the rib and the rib cutter. And again, I can use navigation, put the point right on the rib to know that I'm right over the target disc segment that I want to be at. So it's very helpful here, rather than using fluoroscopy to do this, because it becomes a little bit challenging sometimes if you're not comfortable using fluoroscopy. So the rib comes off, and it's actually a very short video. It's about 2 minutes. I speed through it. So you can see here, I'm just like feeling around. That's a diaphragm, and I need to release the diaphragm on the underside of the T12 rib, and that's what I'm going to do here. That you can see the intercostal nerve and vessel bundle there that's being retracted. And so this is a kidney, and you don't see it very well, but I'm trying to detach the diaphragm from the T12 rib. And that's the first step. And once you detach the diaphragm, I'm just going to follow the T12 rib on the underside of it towards the spine, because obviously the rib is connected to the spine, right? And, but you're not able to see much here, and how do you know you're in the right direction? This is where navigation is very helpful. And that's a navigation pointer, and I'm just pointing to make sure I'm in the right direction here. So that's a navigation pointer. And then I'm going to advance this the video a little bit, and I'll show you as I get further along and I'm stripping the tissues off what I perceive as the underside of T12 rib. And here's a navigation pointer here, and you can see where the point, the blue point is. The yellow is a projection line. I'm on the underside of the T12 rib here. So I'm in the correct trajectory, and my dissection is accurate. Because I follow the T12 rib head, which articulates with the T12 body. I just want to be on the inferior edge of the rib, but I know I'm in the right trajectory here. And so I'm just going to advance the video. So once I ascertain that, I'm just going to keep dissecting along that rib, taking the tissues off the T12 rib. And then you'll see I've advanced this further. And here's a point. I'm on the inferior side of the T12 rib. You can see on the panel to the right, the bottom rightward panel, you can see where the tip is. I'm on the underside of the T12 rib head on the vertebral body, or nearly the vertebral body, above the T12L1 disc space, which is my target disc, right? So this is very helpful, and I'll show you here. I'm just going to finish and that's the pleura and the diaphragm, you can see that. And I'm just going to retract here, and as I progress here, I finally dissected enough that I'm right on top of the T12L1 disc, and that's just a pointer being put in the field in the panel to the left. But you can see on the panel to the right, my pointer is right on the T12L1 disc. I'm near the midline, so I'm just going to advance this dilator tip into the disc space now to anchor it, just like I've showed you in the other video. And then once it's anchored in disc space, I'm just going to sequentially dilate. And put the tubular retractor in place, and then it just becomes a standard operation now. There's a disc space, Not much psoas here, obviously. Psoas ends in this region. And just doing a standard discectomy, but placing the retractor is the most important part, and that navigation is very helpful here. I didn't use fluoroscopy at any step of this process, so no fluoroscopic image guidance at all. This is all done purely under navigation. And I'm just going to progress the video. You can see the cage being the trial being placed, the cage being placed, and I'll do the level below that and use a navigated cob and osteotome to break this fusion. I don't have the video to show that to you, but that would be the next step. And I'll show you the full construct here. So here's the sagittal profile improved, and you can see that with the lateral releases and placing a cage, the coronal alignment is completely fixed. So he goes from, I think it was close to 10 centimeters, I recall, to pretty much neutral here. It's just another example. This can be done very feasibly. This was done all under nav, laterals, and perk screws. As Jehovah's Witness, that's the reason why I show it to you. That with navigation, you could do every step of this process. I briefly want to talk about spinal robots because I think it's an enabling technology. It's built on a platform of contemporary navigation. So if you, in one way of looking at it, a spinal robot is essentially just another form of advanced navigation. I think people would argue maybe it's not, but that's one way of looking at it, because a robot is a mechanical arm that serves as a rigid instrumentation guide. At least that's what it's done now, based on top of a navigation platform. And again, I'm going to go over time a little, but I think it's important to show this. And it has some advantages beyond conventional navigation. But the main point, and I'll reiterate, is it's enabling technology built on navigation. It lowers the barrier for minimally invasive procedures, because a lot of the robots were originally optimized for minimally invasive surgery. But it offers some advantages over conventional navigation. In terms of planning software, you could pre-plan screw and cage placement, and maybe that'll translate. It hasn't been shown yet, but it translates into more consistent operation, be able to plan better alignment potentially. So there's a lot of potential advantages of using this robotic platform. I believe in our infancy right now with this technology, and it will be refined just like navigation has been refined over the last 2+ decades. Here's just screw planning. So you could be very precise in your screw lengths and diameters, more so than what I showed you with navigation, where you're kind of like eyeballing it to a certain extent. You could plan it very precisely, particularly for multi-level operations. I think it's useful. You could plan the cage placement, size of the T-lift cage, where you want it in a disc space. Often we want it in midline, but what if we're trying to correct a coronal alignment? We may want it off the side. So with pre-planning, you're able to do that more consistently and I think reliably. At least that's a promise of this new technology. We just have to show the benefit. But again, it's in its elementary phase right now. As the technology is refined, it'll be just much more useful. I'm showing you here just MIS T-lift, and you can see the robots used in every aspect of the procedure. Again, not using fluoroscopy here. The incision sites, the perimedial incision sites are based on the screw plans. And the screw insertion is very straightforward. We're just going to drill a screw track based on the screw plan, then insert a screw, typically connected to a screw extender, except on the side of the T-lift, and I'll show you why. And then, after the screws are placed, you can see there's the screw extenders there projecting on the right side. We're going to place a tubular retractor on the ipsilateral side. I'm going to get rid of the sound, but you can see on the screen there, I'm sorry, it's small. This initial dilator is being placed based on navigation, not fluoroscopy at all. So this is where the tubular retractor is going to go, and I want it sort of oblique to enter the target disc space. You can see it's very doable here. And then I'm just going to progress the video. I could see after we get the right location, we're going to take the tracking frame off and then sequentially dilate. And this is done without fluoroscopy. And I'm just going to project the video. And then we're going to place a tubular retractor, and then we'll confirm that it's in an adequate position. And then we're all set to begin the laminotomy and the T-lift. But again, this was not done with fluoroscopy. It was done utilizing a robotic navigation platform. Host of navigated instruments, just another video, just a navigated rasper. This is our cage plan. This is where we want our cage to go. And I'm just rasping the disc space. This is the actual cage being inserted. You can see it's going to follow the screw plan. or a cage plan. And that again, I'm just showing that you can put a pointer, certain that you've placed the cage appropriately. Here's just pre and post video. This was done with utilizing a robotic navigation platform. Single position and navigated laterals are definitely doable now. And again, this is a minimally invasive procedure, so one stage operation. And with the robot, particularly the lateral on the downside screws, makes it so much easier. And this navigated robotic platform is done for used in every aspect of the procedure, from skin insertion to the lateral cage insertion. And this is the pre and post-op imaging, again, utilizing this enabling technology. And again, I think it lowers a barrier to attempting to do this. Without this technology, I think you're more reticent to try doing this under fluoroscopic guidance. This is just one more case example really quickly. I know I'm a little over time. Is 73-year-old gentleman who's had a prior fusion. We see this all the time, adjacent segment disease. But this degree of adjacent segment disease is actually fairly pronounced. He's got a coronal malalignment with disc-based collapse. The disc is completely gone. It's eroded the end plates of L3 in this case quite a bit. A TLIF here would be a challenge, right? Here's an MRI. You can see adjacent segment stenosis. This is the L3-4 level. Again, what can you do? Am I slamming TLIF like I showed before? Sure, but I think placing a cage, very much a challenge here, and you may not get that much disc height restoration. Lateral lumbar end right fusion would be a good option, but traditionally it would require a position switch, a two-stage operation, and that's typically a challenge. And I would say two-stage, not single position lateral, because he's got existing posterior instrumentation. So a newer technique is a prone lateral, or I'm sorry, the prone, lateral interbody fusion. But adopting a new technique, a bit of a challenge, as a barrier. But for me, I started to do this technique, and navigation was really helpful. With navigation, I felt much more comfortable doing this particular newer procedure. And Juan Uribe's group in this, paper showed the feasibility of this, and they're using fluoroscopic guidance to do the procedure. You can see it's very doable in a prone position. And there's some advantages over the lateral, not just the fact that it's a single stage prone. And I'm going to use the navigation platform on the robot to do it. And you can see the patient is positioned prone here. And this is a pointer where I'm placing, or the fellow is placing, to mark the skin incision. You can see this is a projected point or line, and it's orthogonal to the target disc space. And this is the navigated dilator being inserted into the disc space here. The plus is the actual point. And then sequential dilation, placing the tubular retractor. You can see the navigated dilator is embedded in a disc space here. Serves as a guide. And then a host of navigated instruments that I've shown before. And this is, it's a collapsed disc space, so I'm using a small navigated cob at the beginning, then larger cobs. And again, I was a little bit concerned that if navigation was off, I'd ruin the end plate. So I did get some fluoroscopic views during this. Again, as I said, you don't want to completely trust navigation. You have to think about it and use your judgment, particularly with these challenging cases. And this is a larger navigated cob, then the sequential distraction with navigated trial, and then the actual cage placement is the expandable cage. And you can see it being inserted here. Often you have to sit on a stool for these prone laterals. And here's a cage insertion. So, you can see the height of disc height restoration here. The coronal malalignment is much improved, and sagittally it looks pretty good. I don't think the discectomy or the prone lateral injured the end plates. It was that way to begin with. It's very sclerotic, and I showed you that in a pre-op X-ray here in the panel which is third to the left. But good disc height restoration and foraminal decompression as well. And just another example of an enabling technology allowing you to do a minimally invasive approach, and it lowers the barrier for entry. So the caveat with navigation, and I think it's important to recognize this, is navigation error can be catastrophic. So you shouldn't blindly follow navigation. You should always try to ascertain that navigation is accurate. And so early on in your experience, I would get spot fluoroscopic imaging to confirm navigation accuracy. And when you get more comfortable, you won't do that as much, because visually you could kind of look down You can see the disc space and put the pointer down. You can have an idea of, that the navigation is accurate or not. So surgical judgment is always necessary, even with these advanced technological devices that we have. Because navigation is one tool. And this is a great saying by Ed Benzel, a former mentor of mine, who was a fantastic surgeon, very thoughtful. And I love the saying is a fool with a tool is still a fool. So, surgical judgment is very, very important. So in summary, enabling technologies can improve the capability of a surgeon. Spinal navigation is an enabling technology that's particularly impactful for minimally invasive procedures, if you ask me. It's undergone multiple iterations or refinements over 2 decades. So now it's a very reliable and consistent technology that could really, I think, lower the barrier to entry for minimally invasive procedures and make you a better minimally invasive spine surgeon. And that's about it. And thank you, and I appreciate your attention.
Thank you very much for such a great lecture, Dr. Park. This has been a very innovative topic. So now we have some questions from our audience. Dr. Madriña is asking, when you use neuronavigation for thoracic pedicle screws, do you choose depending on the level on an anatomical trajectory versus straightforward if desired?
That's a good question. I think it depends on what I'm training to a certain extent, but typically in a proximal portion, I will put, like proximal being higher up the spine, I'll put an anatomic screw because it resists pull out better. So you put a straight in screw, you're depending more on the threading for pull out strength. I mean, you can medialize the screw obviously, but if you place it anatomically so the screw is a little downward pointing, it resists pull out better. So I would put a more anatomic screw approximately. Distally on the spine, I would put a screw that's either straight in or slightly upward pointing, again, to resist pull out.
Thank you. Dr. Park, I have a question regarding the accuracy of pedicle screws. So in your experience, what is the reliability of the planned screw trajectory versus the actual pedicle screw trajectory? Yeah, ahead.
That's a great question. I think Juan Uribe's group had actually a paper on this published in, I believe, operative neurosurgery, seeing what the deviation is from the plan to the actual screw trajectory, and it wasn't very high. And that's been my experience. It's been very close. But if you're, I'm talking about like if you're looking at group statistics, you're looking at large numbers, the mean error is probably very low. But occasionally, if we're talking about like individual cases, I've seen some problems with skiving. So, for example, and if it doesn't enter the pedicle correctly, or because the facet bone's hard, and when you draw the trajectory, it may at the beginning deviate a little laterally, you could be off quite a bit. So skiving, particularly in the lumbar spine, will give you a lateral deviation, and it could be outside the pedicle. And you won't see that because you're tracking the handle, you're not tracking the tip, right? So it can be off. In the thoracic spine, because of the slope of the TP, if it skives, it'll skive medially. So it becomes a much bigger problem in the thoracic spine. And because in the lumbar spine, the way the lumbar facet joint is, when it skives, it'll skive laterally. In the thoracic spine, because it's more, the TP is more like this, it'll skive towards the medially. So it can be an error. So you have to watch that. Like I said, technology is not foolproof. So, you kind of have to, if it doesn't seem right, I'd get fluoroscopic imaging to confirm.
Okay, thank you. Thank you, doctor. Another question, is there a concern for non-fusion when using MIS as limited bone graft may be used?
That's a very good question. And yes, absolutely. Because we're not exposing the bone. So that's a pro, right? We consider that a benefit because without the muscle stripping, that's decreased exposure-related morbidity. There's always a downside to every pro. So there's always a con to a pro. And a con is without the bone exposure, you can't do a good posterior fusion. That's why minimally invasive surgery is predicated on a good interbody fusion. So you got to spend more time doing your discectomy and end plate preparation. So most minimally invasive procedures that are fusion procedures are predicated on interbody work. So if you do good interbody work, I think your fusion rates are pretty high. So the question is very, very, very good question. But if you're going to do a minimally invasive surgery, you should do good interbody work.
Wonderful. Dr. Perez is asking regarding the mistlif. So what is your recommendation? Starting with the cage or the K-wire or the pedicle screws? Which is the recommendation stages do you use?
Yeah, so I mean, it's a good question. You can see through some of my videos, my workflow has evolved or changed over time, right? So if I'm doing a traditional fluoroscopic MIS TLIF, so no navigation, no advanced technology, you want to call it, I'll start off by using a Jamshidi needle and traversing the pedicles and putting the K-wires first. If I'm doing one level at every level, then I'll put a tubular tractor with fluoroscopic guidance, then do a TLIF, and then after TLIF is done, put the screws in over the K-wires. Now, if I'm using navigation, you can use still the same workflow. I think if you're using conventional navigation, you can place the screws first, then do the cage placement, with navigation. Then, so it's a little bit different because screws are being placed first, and then followed out with the cage. On the ipsilateral side of the cage, and you have to have access to this particular type of pedicle screw technology. I don't put the screw head in screw extender on. I just put the screw post. That way it's not in the way up in the tubular tractor on the ipsilateral side. And then once the cage is put on, I'll attach the screw head after the fact. So there's different workflows depending on what type of imaging technology you use.
Okay, thank you. Dr. Onjivi is asking, spinal navigation uses what modality of images, CT or MRI or both?
CT.
Thank you. What are your recommendations for thoracic and lumbar pedicle screw salvage in case of pedicle fracture or pullout during MIS?
That's a good question because that does happen. And it maybe happens a little bit more in MIS. And the reason why is, in particular with fluoroscopic usage, you don't know where the bottom of the screw head is sometimes. You may put one screw down and it's deeper than another screw. So when you're actually inserting a rod and you're trying to get the rod seated, if the screw heads are all offset and there's no spondy or slippage and it's not a mobile segment, you'll end up pulling on a screw. That does happen. So it's very important for minimally invasive procedures because you're not directly visualizing the bottom of the screw heads like an open case. You should get lateral fluoroscopic imaging and take a look at whether the screw depths are reasonable. But let's say you pull out a screw. Salvage options are not great if the bone quality is bad. If the bone quality is pretty good, you can just put a larger diameter screw back in. You can find the screw track with the K-wire, so it's not that big of a deal. But you may end up disrupting the screw track so much that the screw fixation is just poor. And the only real salvage, if you ask me, is to just go up a level or two. It's not ideal, but it does happen.
Okay, thank you. And I have a question regarding the innovations in technology, assisted surgery. What is your opinion on virtual reality, assisted surgery?
Well, I think virtual reality right now is kind of hyped up quite a bit, meaning there's a lot out there looking at it. But I think there's a distinction between virtual reality and augmented reality. Most of what we see that are being done, like Augmetics, for example, is a company with a headset, is really augmented reality. It's not virtual reality. So it kind of it augments it. It puts an onlay of, like, say, the spine image in your field of view. So it's more of augmented reality, and it's based on navigation. So if you ask me, it's a refinement in navigation. And what it does is it takes a screen that you have to turn your head to look at and puts it in your eyesight, so you don't have to turn your head so much. So it's sort of a refinement of navigation. And it's a step forward, and I think it's a convenience factor. So I don't have to turn my head during surgery to look at the screen. I can keep looking at the patient and the spine. So I think there's some promise. Like virtual reality, which is like a completely, say, 3D projection of the spine, as far as I can see, it's done more for educational purposes right now, more so than I think actual clinical application. But I think they're really related technologies. And again, like with any other technology, it's new. It's going to have its issues. It has to undergo refinement over years. And I think it is the future to a certain extent. It's just we're looking at it right now in its infancy.
Okay, thank you. Do you think endoscopy might help for navigated LLIF?
So I think you could use an endoscope for lateral. I know people have tried putting an endoscope down a small incision for lateral procedure, so it's doable. So an endoscope is just imaging technology, right? I mean, you can't put a lateral cage which is 20 millimeters wide, through an endoscopic tube. I mean, that doesn't make sense. But if you want greater visualization, you could put an endoscope down a tubular tractor, for example, during the process. And we've done that in cadaver labs all the time. It gives you great views, and then you may do a better discectomy with a 30-degree angle. You could look inside of this space even. So I think it has some application, but I think it's not popular, I would say.
Wonderful. And what are your contraindications for MIS TLIF?
TLIF? I don't really have very many. I think it's a very versatile procedure. I mean, like any other technique, though, there's certain conditions where it's not going to work as well. Like I showed you one example where the disc space is very collapsed and even a little kyphotic. It's hard to get in. You're working in an MIS TLIF, your entry into a disc space is very narrow and it's not very wide. So if you're trying to lift the disc up quite a bit, it doesn't work that well. I mean, a lateral where you get a broader working channel into the disc space and with wider instruments, I think you could do a better job in terms of disc height restoration. So obviously there's certain conditions where one technique works better than another, but can you use an MIS TLIF for most degenerative conditions? Absolutely. I think it's just your comfort level. And this is where I think navigations can be pretty helpful. Intraoperatively, you put a pointer down, you can see what you're able to do. So I think like any other procedure, there's relative contraindications. If it doesn't look like it's going to work as well, I'd probably just use a different technique.
Thank you. When doing a lateral in which large 360-degree osteophytes are present, how likely would the separation of the intervertebral space and subsequent destruction on the osteophytes are likely to create a vascular injury? Is this ever on your mind when dealing with large osteophytes in lateral cases?
Absolutely. I do a fair amount of deformity surgery, and osteophytic growth laterally and anteriorly is actually relatively common. So I always look at the vascular anatomy. I'm doing any lateral or anterior approach, a vascular injury is potentially life-threatening. So if I'm concerned that an osteophyte intrudes on a great vessel, for example, or I may inadvertently come very close to it, I'll have second thoughts about actually doing a procedure. Having said that, I think navigation is helpful there. You can put the pointer down, see where you are, in terms of your osteophyte release compared to the vascular anatomy. So you can be I think it helps you a little bit there in terms of avoiding a vascular injury. Now, in terms of the degree of distraction, we're talking about typically like 5, 6, 7 millimeters of extra disc height restoration or distraction. I don't think that impacts the vascular vessels very much. I think they tolerate that fairly well.
Okay, wonderful. And I've got the last question for you, Dr. Park. Do you use any software or imaging protocol for post-op measurement of the spinal canal or foramen directly or indirectly compressed as an outcome analysis?
Yeah, I do. It depends on what you're trying to do. For my average clinical patient, I don't do it. If they're feeling better, it doesn't really matter, right? So who cares about the radiographic images if their symptoms are better? Now, if you're talking about research purposes, yeah, there's definitely software. There's I think SurgeonMap is a very popular one for alignment measurements. It works quite well. We have our own PAC system where we can measure foraminal height. So yeah, I mean, it depends. It's mostly for research purposes that I would measure, not for a clinical situation, unless the patients aren't doing well. If they're not doing well, then obviously I'll look at various diagnostic tools to figure out why they're not doing well.
Well, perfect. So on behalf of CIEN, I'd like to thank you once again, Dr. Park. This has been a wonderful lecture, and we are really grateful and honored for your participation in this 2021 IWBNC.
Oh, great. Thank you very much. I appreciate the opportunity. Have a good day.
Thank you once again. For all the audience, keep in mind this lecture will be available on our website starting next week. In a few minutes, we will have Dr. Roger Harrell doing his lecture, Development of a Comprehensive Curriculum for Spinal Minimal Invasive Spinal Surgery. To get a link for this upcoming conference, please follow the link pinned on the chat screen or check the program scheduled on our website, cienhood.com.